My name is Dr. CACS. I'm a non-invasive cardiologist, and today I'm going to be talking about coronary artery calcium scores. In order to better understand what that is, we're going to first delve into the pathophysiology of atherosclerosis, or the narrowing of the arteries of the body, as well as the thought process behind clinicians' management of cholesterol-lowering medications, as well as coronary artery calcium scores. At the most basic level, a coronary artery calcium score is a CT scan of the chest that specifically looks at the arteries of the heart, and specifically the degree of calcification. The basics of the test involves going into a CT scanner or computerized tomography scanner. We gate that image, or we sync it up with the patient's EKG. So when we take multiple slices of images of the heart, we can sync them up to make that moving image look 2D or two-dimensional. A computerized system counts up how much calcium based on the pixel count a patient's arteries have, and it gives us a total score as well as individual scores for each coronary artery, or the arteries that supply the heart itself. But why is that important? It's a surrogate marker of atherosclerosis and future risk of heart attack, stroke, death. The process of atherosclerosis involves the gradual deposition of cholesterol, fat, and calcium within the coronary arteries and the rest of your arteries of your body. This is a chronic inflammatory condition that everyone has.
Let's take a look at this animation to better understand. Here we're showing a cross-section of the coronary arteries and the muscular layer of the artery itself and the underlying endothelial layer. So here in this endothelial layer, inflammation occurs, which causes your immune system to respond and try to heal it. That causes a fatty streak to occur, and eventually it causes deposition of white blood cells, red blood cells, and lipid-rich LDL, and it causes a lipid core to form. That lipid-rich core, over time, becomes more and more calcified. And that's what we're looking at in a coronary artery calcium score. This is a very important part to understand, because just because you don't see calcification on your scan doesn't mean you don't have atherosclerosis. It's simply that we cannot visualize this lipid-rich plaque that is yet to calcify. These are pictures of the raw scanning images that we actually see. On the left, a coronary artery calcium score of 0. On the right, a score of 29. Here, we see much more significant coronary calcium scores. On the left, 250, and on the right, 1200.
Everyone has some degree of atherosclerosis, and we know that patients who have higher cholesterol levels are prone to higher degrees of atherosclerosis, which puts them at a greater risk of heart attack, stroke, or death. Those clinical conditions that are repercussions of atherosclerosis, we kind of group together and call them atherosclerotic cardiovascular disease, or ASCVD. Now, the reason that I bring up atherosclerotic cardiovascular disease as well as cholesterol levels is that you have to understand why we're going to be performing this study in the first place. It's not for everyone, and just like any test, you have to understand what you're going to do with the results and what it means for your patients or you. A coronary artery calcium score is going to better risk stratify our patients to better decrease those risks. It's all about the cards you're dealt and how you play them, the genetics that you're born with and the predisposition that you may have to developing these issues, and some modifiable risk factors like your cholesterol level. Just because you have high cholesterol levels doesn't mean you will have a heart attack, and just because you have low cholesterol levels doesn't mean you won't. But we know that if we could clone one person and give one of them high cholesterol levels, that individual is going to have a higher risk of future heart attack, stroke, death. I think of coronary calcification kind of as the end result of atherosclerosis. The presence of calcium in your coronary arteries means that you already have some atherosclerosis that has developed over many decades and has hardened into calcium. So let's take a look at how doctors manage cholesterol levels. The first thing that every society guideline says is lifestyle modifications. Obviously, healthy diet, low in red meat, high in green leafy vegetables, low in trans fats, low in fried foods, and low in processed foods, as well as diets that help prevent the development of diabetes. Those are generally heart healthy. There's no magic cure or magic nutritional supplement or diet that's going to prevent heart disease. But we've noticed certain trends and certain foods that can decrease your risk of increasing your cholesterol levels and developing atherosclerosis. Things like a Mediterranean diet or a vegan diet. Now, I know that if my doctor said, you have to go on a vegan diet, I would either just lie to them or find another doctor. So it's not that you have to go to those extremes, but it's that everyday improvement in trying to do better than you were yesterday. Because just like atherosclerosis, your diet can impact you over many, many decades over the years. A very unhealthy diet for one weekend ain't gonna kill you, but doing that same unhealthy diet for 10, 20, 30 years is gonna put you at a higher risk of heart attack, death, stroke. So the first thing every doctor is gonna recommend is a healthy diet, healthy lifestyle, not smoking, exercising regularly, and generally just being healthy. But if it was that easy, doctors would be happily out of a job. Back in the day, we used to have absolute cutoffs of where we would want your cholesterol levels to be. Nowadays, we try to look at who the patient is in totality and calculate their ASCVD 10-year risk calculator. What that means is what's their 10-year risk of things like heart attack, stroke, death. Now, if we look at the ASCVD risk calculator, you can look it up online yourself, and it takes into account a lot of risk factors. Things like your current age, your systolic and diastolic blood pressure, your total cholesterol levels, and HDL levels, if you're a current smoker or former, if you're being treated for hypertension, and if you have a history of diabetes, as well as your sex, being male or female, as well as your race, being white or African American. Now, those are the only two races that this calculator has. And it would take me a whole other video to go into the details of why I think that's a little iffy when we're looking at a diverse patient population and trying to use statistics that are made for certain populations that were studied and extrapolating. But that is the crux of this video, and that is the importance of coronary artery calcium score, because these are the only risks that this calculator takes into account. And that's where a coronary artery calcium score can really come in handy. So if this risk calculator has you at a moderate or intermediate risk, a coronary artery calcium score can push your risk lower or potentially higher. Generally, patients who do not qualify for a coronary artery calcium score are ones that really should already be on a statin or other lipid-lowering medications. Those are things like patients who have already had heart attacks or strokes, patients who have a greater than 20% 10-year risk of atherosclerotic cardiovascular disease, or patients who have familial inherited disorders of lipid metabolism. So now what you probably are watching this video for, what does your actual coronary artery calcium score mean? The best score is 0. And the reason for that is that if you have a coronary calcium score of 0, you likely do not require medications to further lower your cholesterol levels. So again, a coronary calcium score of 0, great. You still can have underlying atherosclerosis that is yet to harden and calcify, but it means that at least right now you haven't had it for many years and hasn't gotten to that point. Let's talk about patients who have a calcium score of 1 to 10. Any calcium score that is not 0, I consider abnormal. But you again have to look at that in the clinical context. If someone is 75 years old, I anticipate that their calcium score will likely not be 0. But if you're a 40-year-old who's relatively young and has a calcium score of somewhere between 1 and 10, that means that you do already have some evidence of coronary artery disease, of atherosclerosis that's hardened into calcium. It means that you have minimal coronary artery disease, but it's there and it's already progressing. So those patients can always consider cholesterol-lowering medications after a conversation with their physician, and they really have to focus on lowering their overall cardiovascular disease risk by modifying the things that are in our control. Again, healthy diet, exercise, not smoking. Now, patients often will see attached to their coronary artery calcium score a report that shows a percentile, what their score is compared to other people that have been studied in their age group. Now, again, a patient who has a calcium score of, let's say, 8, who's 41 years old, might be in the 85th or 90th percentile compared to other individuals that are their age. Again, that doesn't mean that you are gonna have a heart attack. In fact, 1 to 10 typically means minimal coronary artery disease, and you're unlikely to have a heart attack. You still can, but patients often get concerned when they see that percentile score. It simply means, again, that any calcification is abnormal, and compared to other people their age, they have a higher coronary calcium score than if their percentile is 90%, than 90% of other individuals their age. If you have a calcium score of 11 to 100, that means you have some mild coronary disease. It means that that calcification is there. It's not just going on in the background, but it is actively progressing. And I bet you know what I'm going to say. You need to have a conversation with your physician and talk about risk factors and consider cholesterol-lowering medications. Let's say you're at 101 to 400. That's moderate coronary artery disease, and those patients should certainly consider cholesterol-lowering medications along with healthy lifestyle and diet modifications. On the other side of things, a score greater than 400 is severely abnormal. In some of these patients, even if you're asymptomatic, without limiting chest pain, shortness of breath, your doctor, after further conversation with you, might still order another test, like a stress test, to see if those large areas of calcification are actually flow limiting or decreasing the amount of blood that gets through that artery. That information we can't see on a pure coronary artery calcium score. We're just looking at the calcium, so we are unable to see What's the blood flow in the arteries of the heart look like? A coronary calcium score of greater than 400 is quite abnormal, but it doesn't go right up to 400. You can have up to thousands. I've seen patients with coronary calcium scores of 1500 and way higher. Earlier, I mentioned that not everyone should be getting this test. And the reason for that is that it was studied in a specific patient population. You always have to know, what am I going to do with this test when I get the results? A coronary artery calcium score was studied in patients 40 to 75 years old. The reason for that is when people are younger than 40, they very rarely have development of coronary calcification, and a score of 0 should be interpreted with caution because it doesn't mean that they can't develop atherosclerosis. It's just that maybe they haven't been old enough and it hasn't been there long enough for it to develop. So it's really not recommended in patients younger than 40, but it certainly can be ordered after a conversation with your physician, especially in those patients who have premature coronary disease or other high-risk factors. And overall, coronary artery calcium score helps us modify our treatment plan. In that same train of thought, patients who are already on a statin medication, where it's not going to be changing our management, it is not recommended that you get a coronary calcium score. So who does benefit from a coronary artery calcium score? Now, in this video, I've spoken at length about people's risk of having heart attack, stroke, death, because atherosclerosis increases your chance of that, and that is what we're looking for in a coronary artery calcium score. But how do doctors actually quantify a patient's risk of heart attack, stroke, or death? We use something called an ASCVD risk calculator. It calculates a patient's risk of atherosclerotic cardiovascular disease. It takes into account a number of factors like a patient's age, diabetes, if they're a smoker, their total cholesterol, their HDL levels, their systolic blood pressure, if they're being treated for hypertension, as well as their race. The only two that are quantified here on this calculator is unfortunately white, African American, or other, and I'll get into that in a minute. But after you put in all of those factors, it spits out a percentage of what your 10-year risk of ASCVD is, or your 10-year risk of atherosclerotic cardiovascular disease. That's where we're able to see, are you relatively low risk, intermediate risk, or high risk? Patients who have a risk of greater than 20% should be on a statin medication. Patients who are low risk are less than 5%, and those patients, it is not recommended that they're on a statin. This risk calculator, just like coronary artery calcium score, was really studied in patients 40 to 75 years of age. And there are other caveats that I've mentioned earlier in this video that also apply to this risk calculator. It doesn't really work well for patients less than 40 years of age or patients greater than 75 years of age. And that's where that conversation with your physician really comes in. Now take a look at the central illustration from an American College of Cardiology review article on coronary artery calcium scores. It gives you a good example on the top row, a patient's 10-year ASCVD risk. That's their risk calculator that we use. And it shows you those 4 levels that we talked about. Less than 5% low risk, greater than 20% high risk. Those ones are the easier ones. Statin's not recommended for less than 5%. Greater than 20%, you should be on one. And similarly, neither of those populations have use for a coronary calcium score because it really is not going to be changing our management. Again, you can still have it done if you talk to your physician, but based on these guidelines, it's really not recommended. Like many tests that we use in cardiovascular disease, it's the people that are in the middle that most benefit from a coronary calcium score. So let's take a look at that second column, 5 to 7.5%. If we're just talking to our patient alone with just that piece of information, we can convince ourselves one way or the other, do we want to be on it? If a patient tells me they want to do everything they can to decrease their risk of ASCVD, then we can start a statin and we don't need to do a coronary calcium score. Conversely, if a patient says, you know, doc, I'm fine taking medications, but I don't want to if I don't need to, that's an ideal patient to then get a coronary calcium score to either increase their risk profile and reclassify them as higher risk, or lower their risk and say, you know what, even though this risk calculator said you're in that intermediate range, based on your calcium score, you're actually lower risk, because no risk calculator is perfect. Similarly, in that third category, the greater than 7.5 to 20%, we really should recommend a statin in those patients. Those patients, we can also get a coronary calcium score, and if they have a calcium score of 0, you've heard it already, they do not need to be on a statin. Conversely, if it's anything else, they really should be. So ultimately, what I try to help people understand with coronary calcium scores is that it is going to help us reclassify patients as higher risk or lower risk based on more physiologic information. Doctors aren't perfect, and we look at all the data that we can This gives us more information to better treat the person in front of us. One last point that I'll make about the ASCVD risk calculator and about patients who might think about getting a coronary artery calcium score. These are patients who have risk factors that aren't taken into account in the ASCVD risk calculator that might prompt me and my patient to pursue a coronary artery calcium score. These include patients with familial hypercholesterolemia, chronic inflammatory conditions like CKD or chronic kidney disease, rheumatoid arthritis, SLE or lupus, premature family history of atherosclerotic cardiovascular disease. That's first-degree relatives, parents or siblings, who have had heart attacks or strokes, people with metabolic syndrome, women who have had pregnancy-related cardiovascular complications like preeclampsia, lipid biomarkers. These are blood tests that, kind of like a coronary artery calcium score, might help push a patient into a higher or lower risk category, although I still think the coronary calcium score is superior to these. But it's still more useful information. These include elevated high sensitivity CRP or C-reactive protein, elevated lipoprotein A levels, elevated ApoB levels, or evidence of peripheral vascular disease like an abnormal ankle brachial index, as well as individuals of South Asian descent. We know these individuals have a higher risk of atherosclerotic cardiovascular disease, and those individuals' risk can be underestimated in the contemporary ASCVD risk calculator. One more thing I want to talk about in this video is the cost of the test. At the time of filming this video in July of 2022, for some reason, it is not covered by insurance. Patients have to pay for it out of pocket. It typically costs, $100. Don't quote me on it because healthcare in the United States is weird, but you should know that this test is not going to be covered by insurance and it's going to be an out-of-pocket expense. So if you or a loved one is getting a coronary artery calcium score and you're a little bit confused, send them this video. Hopefully it'll help them understand it before their next appointment with their physician. Now I know that was a lot of information, but I like to provide the full train of thought of what doctors are thinking when we're ordering tests, specifically a coronary artery calcium score, and the repercussions of what we're going to do with that information. If you found this video helpful, I'm happy to answer any questions or concerns in the comments. I cannot and will not comment on your specific conditions, but I can answer general questions about cardiovascular health. And if you want to see a new video about a different topic concerning cardiovascular disease, drop it down in the comments and I'll add it onto the to-do list. And follow, like, share.